Hey everyone, thanks for coming tonight. We're really excited to host Dr. Joel Carmichael. He has a very interesting backstory. He was on the medical team for the Olympics in 2012 in London for the USA beach volleyball team and still kind of maintains a practice with the Olympic team and is going to Portugal with them this summer. He's here to talk to us about kind of the research arena and kind of the chiropractic perspective, which should be very valuable to incorporate in our practices. So I'd like to welcome Dr. Carmichael.
Well, thank you, guys. Can everybody hear me? Okay. If I step away sometimes, can you still hear me? So, how many people here how many people practice manipulation? Yeah, in school? Okay. Osteopath, PT, et cetera, et cetera. How many people have ever received spinal manipulative therapy? All right, so the orthopedist I was talking to last week, we did a little research kind of meeting. He's going like, I don't know how it works, but I love it. And so today I'd like to provide some answers, but also probably lead to more questions, which is it's the nature of science. But anyway, thank you all for allowing me to speak today. As a first order of business, I have nothing to disclose. And objectives for today, presenting relevant findings from a new concussion study that we completed in December of 2017 using UC Health and Children's Hospital data. Also to provide a brief overview of chiropractic history, education, and practice. So the same blow to the head-neck complex that produces a concussion, we think, can also produce a neck injury. Like, duh, that makes sense. So the question is, how often does that occur? And the answer is, well, it's never been studied. And so we undertook a study of that very question. So first of all, concussion is a hot topic, as you know. I'm pretty sure everybody in the room is interested in this. And most concussed high school athletes present with between 2 and 8 symptoms. So if you look at this is taken from a typical 22-item symptom checklist. And you can see that headache is by far the number one complaint, and then it goes down a little bit. But what you're also noticing is that neck pain isn't on the list. Well, if it were on the list, where would it be? And again, that is the study question. Of the 22-item checklist, 19 symptoms do not differentiate between concussion and symptoms of cervicogenic origin. So for us, we need to be careful to look at that. And this study provides some insight for us. So what we do know is the prevalence and incidence of concussion. It's been studied in high school students, NCAA, professional students, even some youth studies, but usually in a nationwide fashion and rarely in a community environment. Well, we've got data from our community, University of Colorado Health and Children's Hospital, and so we're going to use some data. We know that the incidence rates ranges between 2.3 per 10,000 overall athletic exposures as an overall statistic to 40.2 concussions per 10,000 athletic exposures in American football. We also know the prevalence and incidence of neck injuries, again studied independent of concussion. We know the prevalence ranges between 2.6 and 7.5% of all injuries sustained in contact sports. This is from Dr. John Leddy, who's up in Buffalo. He's done a lot of research in concussion. And also, the incidence rates range, again, between 1.14 and 6.38, in this case, per 10,000 participants, not per athletic exposure. So, again, it's kind of hard to bridge the concussion data, in some cases, from the neck injury epidemiology. So the aim of our study was to describe the epidemiology of neck injury among youth sustaining sport-related concussions. The rationale is that there's few studies among youth before high school, there are no community-based studies, and there are no studies examining concurrent neck injuries among concussed youth. Our methods were to extract de-identified data over a 13-year period bearing at least one concussion diagnosis. The records met selection criteria. We were searching concurrent diagnoses indicating non-catastrophic neck injury. That is a sprain, a strain, or a whiplash, certainly not neck fractures, certainly not spinal cord injuries, and so forth. We also coupled that with keywords identifying competitive or recreational sports. Our study did not differentiate between competitive or recreational as directly associated with the inciting trauma. And then any concussion follow-ups that were done within 90 days of the first concussion were regarded as a follow-up study, just out of the box, and we rejected those, wanting to limit our study to only first concussion encounters. The probabilities of neck injury diagnosis among concussed youths were compared between sexes and sports. We calculated the neck injury proportion ratio, which is a measure of risk. And an example of that would be here. The female to male injury proportion ratio is the number of girls with a neck injury over total girls concussed divided by boys' neck injuries over total boys concussed to give us a female to male injury proportion ratio. We counted concussions as concussion episodes, and that was our denominator. We also calculated confidence intervals, and we used this data for our analysis. So, over 13 years, we located 31,000 concussions in the combined database from January of 2003 to August of 2016. We again excluded age range that's outside of 5 to 21. We excluded comorbidities, including neoplasm fracture, central nervous system disorders, spinal cord injuries, etc. And then again, that 90-day window. We then yielded 16,885 concussions in youth between the ages of 5 and 21. Of those, we identified 3,040 that were sport-related and 2,775 that were non-sport. And you're saying, well, wait a minute, what's the difference? The difference is 11,070 cases that we don't have enough data in the electronic health care record to know whether it was for sure sport. Prompts in EPIC, perhaps. So we'll look at that. And then of the 3,040 sport-related concussions, 220 had a concurrent documented neck diagnosis. In the 2,775 non-sport concussions, 335 encounters documented a neck diagnosis. So this is the busy slide of results, and what I want to do is kind of narrow it down to some brass tacks here. What we see, the overall sample, a prevalence rate of neck injury among concussed youth of about 10.5%. This is prevalence again. This isn't across a 13-year period. Note that in the non-sport related, there is a 12% prevalence, and there's a spread of 9 to 16% male among the UC hospital sample, which was 41. It hovers around 10% overall and about a 4% spread. Hospital came through for us 12,700 concussions. Got a huge note that the prevalence of neck injuries among sport concussions, 7.24%. Bulk of our conclusions are going to focus on why that might be. And, we can put our heads together on that one. So another interesting finding is that in our overall sample, the mode or the most prevalent age of concussion was 15. At the age of 14, we notice also the Gaussian distribution, the normal distribution. Why do concussions overall Why do neck injuries among concussed athletes? Well, why is there a normal distribution? Present in the older and younger groups. This is the neck injury proportion ratios that we calculated. This is non-sport to sport by age, meaning that there is a statistically significant higher risk of neck injury among non-sport related concussions than there is among sport related concussions. So these stars indicate statistical significance. Non-sport to sport. And then this is an analysis of sport. The prevalence of neck injuries, females to males. This would be the risk. Snowboarders, females have a 4.65 times higher if they've sustained the concussion. And again, hockey, running, bicycling, skiing, lacrosse, this is where we cross the line. This is all females to males, a higher risk. Basketball is non-significant. Equestrian is also non-significant because it crosses the null value of 1.0. Football, you're saying, what? Females playing football? I go, this could be. But for softball, soccer, and football, of course, males had a higher risk of neck injury among the concussions. Then finally, we calculated injury proportion ratios. This is for all boys concussions, the percent concurrent neck injuries, and you'll see that by far, football has the highest overall prevalence of concussion and also a respectable prevalence of neck injury. Here are the statistically significant sports involved. Here we have very few concussions overall in these sports, and we're not able to achieve any statistical significance. So this is the boys, and then for the girls, number one sport here is soccer, and we also notice a pretty good balance here in volleyball. And again, in my practice, we see a ton of high school girls, and they're blocking the ball with their face all. Going low. Here we go. And again, the statistical significant sports, soccer, volleyball, equestrian. Again, there's a really good chance if you fall off a horse, you're going to injure your neck and get concussed. And then the overall figures, again, the highest by far, football, soccer, basketball, and both sexes combined in terms of risk. So, I'm mentioning the limitations first, just so we can concentrate a little bit more on the hypothesis generating attributes of this type of a study. This is a cross-sectional study, so no causal inferences can be made. There's a limitation there. Also, we chose all records to eliminate the risk of selection bias, but of course this strategy limited us to those who don't see doctors. We also relied on the diagnostic codes that were in the electronic health record, multiple provider types with differing expertise. Who does a concussion person see when they come to one of our community stars? Whatever. Who do they see? Do they see a nurse? Do they see a physician's assistant? An ER doc? Physiatrist? Who do they see? Yes, pretty much all the above. So there's a varying expertise level there, and that could underestimate probably the number of neck injuries and the prevalence of neck injuries we came up with. And then we collapsed our keywords, as I mentioned. Running doesn't refer to the track and field sport. It refers to what was in the document as far as in baseball, but it would have gone down. That may not, we that in as a just run. Colorado, we defaulted to snow skiing rather than water skiing. And my apologies if that's an offense to those of you who are boat owners. So our conclusions. The overall sample, there was a prevalence of 10.5%. In the non-sport related concussions, there was a prevalence of 12.1%. In the prevalence of neck injury, that is 7.2%. Does that sound like the true state of nature? So we're going, what's up with that? And that's where the results of this are exciting to some of us. That right there is not cool. So prevalence by sexes, again, we're just going through our overall findings. There's a 6% higher prevalence in females overall and in the non-sport related concussions. 1% higher in females with a sport-related risk estimate calculated 1.5 to 4.5 times higher risk in females overall. Risk estimates by age 1.6 to 4.6 higher risk for those between the observations. So, why the low prevalence of neck injury diagnoses observed in sport-related concussions? Is it lack of standardized examination? All about, Will Smith and my boy, if we see a sporting off the field, they're still in their jersey, they got their cleats on, they're in the examination. Boom, concussion. If it's a motor vehicle accident and they're are we more likely to carry our then the study's worthwhile. Might not be that hard to fix. One thing we could do is to include discriminative tests between cerebrogenic and some of these don't have validation studies yet. I'm not recommending. And again, I've got my PhD mentor in the room. Oh, we're not going to do that validation study. I'm not going to do a validation study. But these studies need to be done. Secondly, okay, so here's just an example of some tests. The head and neck differentiation test. Move the whole body, move the neck. You get more symptoms with neck motion. You're firing the mechanoreceptors in the cervical center. Validated. There is the neck flexion rotation test, which I use to elucidate blockage there. And but it's also good, if there's joint blockage after a concussion, maybe not all the symptoms are cerebral. Finally, smooth pursuit test, having them track visually. Find a little bit more. And these tests, they're worth knowing about, and they're worth doing concussion evaluation a little bit further. The second thing is something I alluded to earlier. They've got a jersey on and some cleats. They've got a headache and a little fogginess or whatever, and we're locking on using anchoring bias. These are kinds of cognitive bias: anchoring bias and availability bias. Lock onto something too early, and then we don't carry. Availability bias is the fact that we're drawing from our recent experience. So, the remedy could be updating the EHR to include prompts, to neck exam and some documentation practices, including in the history of onset, because we had 11,070 cases that didn't action. Why is there a normal distribution diagnoses? The neck across ages 14, of course, among girls more than boys. Is there a lack of head stabilizing neck strength? Are there muscle activation deficits during pubertal development? Are there differences by age and sex? And future research, do activation deficits exist? Protocols, and when should those protocols be incorporated? PM&R department, crusade. Or the incidence and prevalence. Should this be done? Well, I call that bobblehead syndrome, by the way. That's the lack of head stability. This is a study from Scotland, of all places, ages 12 to 18. This is neck strength. What I want you to look at is these median numbers. The question is, are we demanding too much of our youth? Is there something that we could do about it clinically? Well, this study, I have Don Comstock on it and also Bob Cantu. Health and concussion. They believe that neck strength is a protective factor. Operationally defined and implemented community-wide. So I want to thank all of these people for their gracious those 31,000. If you're not familiar with Health Data Compass, also Carrie Prideaux from. So research doesn't happen in a vacuum. Okay, so now let's see how much time do I have. I got some time to talk about some chiropractic practice. I'm kind of excited about this. This is a case I saw today, brand new patient. Okay, so here's what we're going to do. We're going to lie this person on their side. We're going to drop from the chandelier and we're going to bunny hop the spine, right? Obviously, no. Well, the interesting thing, this gentleman, I will say it's a gentleman. I want to ask you, survey, how old do you suppose this guy is? 74, I heard. Anything? Higher, lower, higher, lower. There is a prize at the end. I know what you're doing. No, 56? Very good. Okay, so this guy is 63 years old. How in the world do you get a spine like this at the age of... Set arthrosis and a degenerative spondylolisthesis. I gave you just one shot, so you don't get to see the whole thing there. But I will tell you that this gentleman, back when I saw him before, he presented 22 years ago. I think this guy has leg symptoms. Image. Answer that one. I thought this was fun. Gathering here. 180, child's pose maybe, but we're not doing upward dog and cobra and prayer twist. We're not doing all that stuff. Questions? Believe it or not, he has no leg. He has some burning across his low back, but rarely does he need to take the combination. Not playing tennis, but oh, he makes his way through an adaptive golf. No, he didn't bunny hop his. A whole lot that I as a chiropractor can do. This is that this guy at some point, he was looking at his sagittal T2 there, going better looking, and I'm going out the picture. Cut the screws. I got a new Dynasys. I wanted to provide this as a he had a gastric bleed. He was buddies swallowing ever. That was a good call. Okay, so that's a little conversation starter. It's been a profession. Chiropractic has been in existence. The licensure in 1915 by the Colorado State Board of Medical Examiners, actually. And it was defined back then as the treatment of disease by palpation, nerve tracing, adjustment of the vertebra by hand. So, a little tour down memory lane. Gallup poll recently said that 5% of past year chiropractic patients said it's effective. This is their opinion. 7% would likely seek chiropractic care again. DCs are included in all NFL teams and many U.S. Olympic teams. Added chiropractic through its pain management standards. Increasingly accepted by physicians, hospitals, medical institutions, and third-party payers. This shows the increased utilization both globally, and you can't really see that thin blue line, but it's there, in U.S. and also globally, and also in Canada. 7% up to almost 11% over a 35-year period. Anyway, get the idea. The most common complaints that are presented to a chiropractor: back pain, neck pain. Kinds of things that I talked to with our patient this morning. So the minority of DCs, again, that's less than 10%, I think is less than 7% now. They believe it's mediated through the nervous system. For health, including and you can easily disprove it. And no, I don't reposition bones that are out of place using. Buckley said the great tragedy of science is the slaying of hypothesis by an ugly fact. So the majority of DCs hold to some elements of traditional philosophy, and that's disturbing even to me. And they use a variety of interventions, not just manipulation. exercise, dry needling, myofascial therapies, nutritional advice, and supplements. And they embrace and assimilate published scientific evidence. So that's refreshing, and it's getting better all the time. And then there's evidence-based chiropractors. That's about 20 or 30%. They limit their practice to musculoskeletal conditions. Their practices are very similar to advanced. And they often refer to physicians, surgeons. My only difficulty in not mechanism of actually just getting those guys in. You guys are already busy enough, but taking a new person, have a greased pathway where I can just get these and have them ready to go. So pre-chiropractic is 2 years plus, 60% have a bachelor's, 80% have a master's. Training is 4,200 plus hours, 2 years of basic science, clinical science and practicum, another 2 years, 3-part board exam, then state boards and postgraduate continuing education required. To get my board certification in sports medicine, 15 accredited schools, 27 outside the U.S. Why didn't I go to Switzerland? Well, most chiropractors practice in private practice down here. Over 1,000 chiropractors now practice in hospitals. Particularly, California is the first place, but we've got chiropractors in lots of high places. Dr. Haldeman was D.C. first. Science, and then an MD practicing neurologist in Santa Ana, California, and president of the task force 20 to 2. I did my residency under Dr. Cassidy, Saskatoon. He was getting his got a Dr. of Med Science from Karolinska, Stockholm. Bill Moreau, he's the vice president of sports division in there. This is kind of a who's who, but do you guys remember Ralph Gay? Any of you guys? He actually wrote one of the letters for me to actually get. Definitely appreciate his influence in life. Howard Vernon, a chiropractor, he came up with the Neck Disability Index, which is now the gold standard. Important paper of the last century, whatever. But, that's the way to do it, is just create an outcome. So what is manipulation? This thing here is the active range of motion in the white, passive range of motion beyond your active range of motion. Non-passive, there's this thing called the paraphysiological space, and that's where we carry the joint when we. And some manipulations are done, many postures and positions, but I'm talking now about high velocity, low amplitude, grade 5 manipulation. So, the nomenclature, those of you who are osteopaths might use somatic dysfunction or joint dysfunction. Variety of things that can confuse topic. I prefer joint dysfunction. Looking at what the effects of immobilization are so we can appreciate the need. So, looking at impaired joint nutrition, basically, articular cartilage degradation, and then these things, intra-articular adhesions, can limit the mobility of facet joints in the spinal column. And these are amenable, we believe, to manipulative therapy. So we see these things, these are our intra-articular synovial folds, and when they become entrapped, they can actually potentially produce invagination of the capsule. Another theory, here's the synovial tag seen in cross-section. These are real. In fact, there's been some studies that do some guys do? What are you doing? Other studies that show that your medicine leaks outside of the capsule and goes everywhere. We're hoping we're hitting the recurrent nerve of Luschka in a medial branch block, and then we carry that on to a radio frequency ablation. I wanted to show the graphic extirpated. There's actually there's more capsular tension. I'll show you in the next slide. More capsular tension. Doggone thing is extirpated. Well, that's a theory. Theories of mechanical dysfunction. And again, here's the innervation of the facet joints, which you guys know now or are learning very well as you move into injection medicine. Triple joint complex simply states that anything that affects the posterior facet also affect the anterior column. They are mechanically linked. Some of the metabolism of the intervertebral disc. Referring mostly to the work of Jeffrey and Joel Saul. So, the postulated effects of manipulation are entrapment, or by freeing up extirpated synovial by down-regulating intersegmental. Well, we don't know. That's kind of the conclusion, is that we know a lot, but we don't know a lot. This is the short interval intracortical by transit. Of the high velocity, low amplitude manipulation. So we think there's a difference. Again, what does it mean? There's evidence to support a central mechanism, but not nearly enough evidence to show it. Bottom line, there are several postulated causes of joint dysfunction that are anatomically demonstrable, but mechanisms of action for spinal manipulative therapy are still best or unknown. So again, it feels good, but why does it work? Okay, let's look at some evidence. This is from JAMA 2017. This is, I think, October or November. And they did of manipulation for acute back pain. This one was March 2018. So I just did a little quick search. Last 5 years for low back pain and 6 for neck pain in the last 5 years. This is spinal manipulative therapy. And one of these papers, that first one from JAMA, showed that outcomes, they favor manipulation. Functional outcomes also favors manipulation. It doesn't fix anything long term. Beach volleyball player. Okay, and so the summary here for the neck pain systematic review, this one from adverse events, we'll talk about that. There are no studies that compare the difference between 5 and any other grade. Therefore, it's unclear if certain are effective than others. We just don't know. The Annals of Internal Medicine, April 2017, had a recommendation from the American College of Physicians. That includes a recommendation for massage, acupuncture, or spinal as a non-pharmacologic intervention. Prognosis, this is important. This is meaningless. Pretty good and have a little bit of that's always. How many of you guys are they throw up the x-ray and then they draw. How about if you say you need 3 times? That's just my opinion that's recorded. Second recommendation for chronic low back pain also included spinal manipulation by the American College of Physicians. So, finally, Richard Deo said that none of the trials in this study, this systematic review, showed that SMT was less effective than conventional option for people with low back pain. So, adverse events for lumbar manipulation, disc herniation, fracture, cauda equina, 1 in many millions, according to this. And Stanley Rubenstein, who does a lot of smart dude, he's over in Holland. And then let's talk about the elephants in the room. What about vertebral artery? Exactly. What about that next person? Helping people. So there needs to be a high index of suspicion. RA, systemic. So I'm going through this list. And stop thinking. Non-high velocity techniques have equal clinical benefit in most clinical contexts, and so should be considered when appropriate. This was a study commissioned by the VA by Paul Schickel and Page. And here's their comment. There have been adverse events of spinal back pain for neck pain. Causality. Not being able to calculate frequency. If we could, we would. but we're not there. So how might a DC be integrated into multidisciplinary spine practice? Again, I'm not even going to talk about sports medicine. A member of the spine team, they're independent. I think that's important. Evaluation of spine complaints by referral, and treatment of uncomplicated spine diagnoses. Management of chronic intermittent mechanical back and neck pain as an alternative based on patient preference. And you're going, send them to the physical therapist, who's a specialty trained physical therapist, and let's have us manage those folks for you guys, so you can stay focused. Well, there's a primary spine provider model that's put out by University of Pittsburgh. 30 chiropractors and 30 PTs, and it's kind of interesting if you go to psp.pit. Kind of get a little feel for what they're doing. What they're trying to do is offload and make more efficient their spine practice. It's one possibility. So the summary is that chiropractors, like physicians, use a variety of therapies. There's good evidence that spinal manipulation is safe and effective for common and uncomplicated. And evidence-based chiropractors could be valuable members of the healthcare team. Questions? That's good enough. Oh, you were related to the first. Right, so I wonder. Prevalence of neck injury among happens in ACL prevention. It works. It's part of that. Nobody wants to do it. But nobody to tell the athlete that this is apart from the old bridge ups that we used to see.